Right, 2 o'clock. I'll begin. Good afternoon, everybody, and welcome to this afternoon session looking at PROMs, interoperability and semantics, and how PROMs are trailblazing an open architecture model for NHS Wales. I'm Stephen Frith. I'm the Programme Director for Digital Services for Patients and the Public. And I'm introducing this session, so I'll do a brief update and background onto about the programme. But before I do that, I'll introduce my co-presenters. There's Saeed Shadi from Value in Health and Care Wales, who will be doing a slightly deeper dive on the technology and the interoperability of PROMs, and Angela Parrott from Cardiff and Vale NHS Trust Health Board, who will be describing more of the detail about the PROMs activities within the Health Board in Cardiff and Vale. So, and then we'll pause at the end for a question and answer session, which Saeed is going to coordinate for us. So just to introduce the session and provide a background for those that are not aware of the Digital Services for Patients and the Public programme. If I can have my first slide. The one way to describe what we're trying to do with DSPP is to look at the kind of historic systems that we have and know and love within NHS service delivery, which are often referred to as kind of silo systems. So you've got large patient administration systems and radiology systems, pathology systems, primary care systems, and I'm the first to say we should make no apologies for these large systems, because they're operational, they support complex service delivery, and they've been developed over many years and they work. But we have found them to be somewhat limited when we want to do data interoperability and to compare data and compile data sets across multiple different operational systems. However, over the last 20 years, we've become pretty good at building data warehouses and aggregating data into offline repositories, and to build solutions and services that take data from these multiple operational systems, and that's to support service delivery, clinical research, clinical service delivery, but less so to support patient access. And one of the points I want to kind of get across about how DSPP has been set up is not really to create another horizontal slice across the various systems and create another data warehouse type environment that members of the public and patients can plug into, but is actually based on a more kind of sophisticated technical ecosystem and environment that is very much aligned to the vision for the National Data Repository in Wales and the concept of access to data through APIs, but also that kind of spins the whole model on its head. So if I can move to my next slide, and consider the view of the health and care environment from the patient perspective, where the patient is very much in the middle of a complex range of services and wanting to increasingly access those services through digital channels. And by and large, what that really means is downloading apps on mobile devices and tablets and using these apps to engage with the service, book appointments, see detailed health and care information, access health and care information. And a quick look at this slide and the complexity of the environment that individuals want to interact with. It's wide and far-reaching, and that's one of the key points really that underpins the DSPP vision. That this is not something that one individual programme or a team of people can do alone. It has to be many different people and parties marching in step to try and create a more consistent user experience for a number of reasons, but not just the actual experience and enablement of new models of care that digital channels operate and improved user experience, but actually for security, matters of trust around the data, efficiency and cost savings. There's a number of reasons why everybody marching in step will create a better experience for everybody. So the DSPP vision has been set up to kind of help facilitate that and create a concept of a core platform of services that people can access, but also innovate around the edges and the outside, and particularly on the interface between members of the public and service delivery. And setting it up that way is kind of essential, because no digital service can really be deployed in this environment without a corresponding service transformation agenda. Or put another way, you can have the best online booking system in the world, but if the service is not exposing bookings in that way, it won't get used. It'll just be sat on the shelf. So the service has to transform the way that it delivers care. And the design of those service transformation and models of care need to be undertaken locally between practitioners, care deliverers, members of the public and patients, and the technology needs to kind of be secondary and subservient to those design models. So that's why it's set up this way around, to facilitate the innovation and service improvement on the edges, but provide a consistent set of core services in the middle. And what we mean by core services, and the ones that are absolutely critical and of relevance to this conversation around PROMs, are the data interoperability, the movement of data from the NHS data domain into the public domain, and the capturing of data from the public domain and moving it into the NHS and health and social care domain. And moving that data out and capturing that data and moving it in, the kind of the national architecture and the review in Wales has zoomed in on the approach that's often referred to as API management. And in some ways the easiest way to think of APIs, because it's a term that's used and thrown around quite a lot, but really it's just a piece of code that sits there and allows one application to access functions within another application, a bit like having a key cut for your house, and then you can give that key to people and they can come into your house and access various parts within it. And it's quite an interesting analogy, because actually just having your key cut is only half the job. You know, you can choose to leave it under a plant pot by the back door, but actually in general you're going to want to know who's got a copy of the key, when they've used it and for what purpose they've used it, and that's why an access control model sits comfortably on top of that kind of API access model. So you know who's basically picked up the key and who's used that key to come in and to take data out of the NHS system, and that supports this kind of federated development and innovation of ideas, and suits the development of many different functional areas, including PROMs. So it means that a service area with a desire to deploy some kind of PROMs type enabled care pathway, they can procure a solution off the market. That market can be accredited to plug into this environment. That solution can be an expert at presenting PROMs to individuals and helping individuals enter information into that particular PROM, and can collect it, store it in the kind of the architecture that Saeed is going to talk about. And the API can facilitate the process of doing that. And the second service that can be that the DSPP platform will enable is the identity management. So making sure that we've got a consistent approach to identifying individuals and to authenticating them as they use an application, and to start moving towards listening to patients when they actually challenge the data that we know about them. And simple things like changing address or phone number, we can improve the way that we capture and disseminate that information with a more direct relationship with the individual patients and public. And we can facilitate that as a core central service through the DSPP core platform services. And the two more things in the core service that are worth touching upon. One is start to look at a consistent set of rules for information governance to control what's possible and what the legal interpretation is of engaging with patients and using digital channels. And the fourth area is to wrap all of that up in something that we call the gateway application. So a kind of it's not the only way that a patient can interact, and there's multiple routes for this, but in a lot of use cases the journey would be that the gateway application, which at the moment is being called the NHS Wales app, is downloaded by a user and it's used as their kind of common point of entry, and it provides that identity management authentication function, but then is used as a springboard to step into other services like the PROM service we're talking about today, or like services to help people living with diabetes, or services to help people with heart disease, where the subject matter expertise is provided by a peripheral project and typically a third-party solution and set of technologies, but it all links together and creates a more seamless, holistic experience for the member of the public through the gateway application. So that's a quick trip around the houses for the DSPP programme vision and architecture, with a particular view on supporting activity around the edges in different use cases, and hopefully setting the scene for a slightly deeper dive on PROMs. If we just move through a couple more of my slides before I hand over to Saeed. I mean, I'm kind of guessing that most people on this call are converts to digital services and familiar with digital services, and you know, we use them all the time in banking and taxing cars and paying parking fines, etc. Every time we interact through our mobile phone, that's a digital service. And in many ways in the NHS, we're a bit behind the curve, and we've done quite a lot of talking to users and members of the public to find out what they want. And it's pretty clear that they are thirsting for access to health and care services through digital channels, and also the services providing it. There's a lot of services now available and popping up through the health and care environment in Wales, and what we're trying to do in DSPP is underpin those with a set of shared services and core platform services to create a more efficient model and consistent model for users. But the benefits are, in my mind, twofold. There's benefits to the individual in terms of improved health and care outcomes. They're more involved in their care and the decisions about their care. We know that, and we know that leads to better care. But also it supports the development of new models of care and reduces the burden on the NHS by having much more appropriate and focused engagement with members of the public. And as well as supporting this kind of activity in PROMs, we're supporting a project in an Owen Bevan Health Board with PSA testing that allows patients to be far more proactively involved in the management of their care. And there are a lot of areas where digital services can help people both have a better experience, but also help the NHS deliver a better service. And if we move on to the next slide, this slide really summarises the concept of the DSPP providing an underlying framework or platform of core services, where we assist with tools to support data exchange, data interoperability, and identity management of individuals, but also as we move forwards, move into this kind of concept of a centre of excellence, where everybody working in digital services for patients and the public can come together and share their experience and say what works and how they've done it, and we can spread best practice across Wales. So that's the vision for DSPP. We're running webinars every couple of weeks for people that want to hear more, so do reach out and get in touch. But this session today is not about digital services for patients and the public under DSPP. It's very much about PROMs, and there's a lot of activity going on in the health and care environment about PROMs and using the opportunity to capture data directly from patients. So with that introduction, happy to take questions on this later, but without pausing, I'm going to hand over to Saeed now to give a bit more in-depth presentation on the approach in Wales that's being adopted and pursued under the Value in Health and Care Wales programme. So thanks very much. Over to you, Saeed.
That's great. Thank you, Stephen. Thank you for the overview of the DSPP programme and the work to deliver a shared core environment of services. It's great to be here. My name is Saeed Shadi. I'm the Assistant Director of Health Informatics, Analytics and PMO for the Welsh Value in Health Centre. So in my session, I'm going to talk about the end-to-end touch points for patient-reported outcomes and the amazing work to deliver a standard operating model for PROMs known as PSOM, which has been delivered for the benefit of all health boards and trusts in Wales. I'll also reference where our work aligns was the core services Stephen refers to later on. So once I've finished my session, I'll obviously hand over to Angela to talk about what Cardiff and Vale are doing. So this session obviously assumes you are familiar with PROMs. So if you're not, then there was an excellent session on Tuesday titled Introduction to PROMs Analysis, presented by Amanda Willicott and Robert Palmer, explaining PROMs that you might find useful. Now, if you attended sessions earlier in the week, one of the key themes emerging across a number of these sessions relates to PROMs interoperability and how we deliver this. So hopefully that journey will become clearer in the short presentation. Next slide, please. So the national approach we have taken for PROMs is defined through what we refer to as PROM. That stands for the PROM Standard Operating Model. It's about a set of standards and principles defining several key components to help us achieve our target operating model. So firstly, it's about data and processes. These are interlinked. So the processes refer to the schedule of collection. So it refers to the schedule for collecting PROMs across a pathway, which I'll illustrate in the next slide. The data refers to the structure and semantics of how we encode PROMs questionnaires and patient responses. This will hopefully become clearer in later slides when I talk about our information specification standards. Secondly, it's about technology toolkits. This is about the interoperability technologies we will use to support information exchange, i.e. how we communicate between the patient device and the health board, and packaging of the PROMs data, i.e. the patient completed questionnaires. Now, what is already proposed at a NHS Wales level is to adopt the international HL7 FHIR standards for information exchange between key systems and health boards and trusts. What is still to be defined is the standards we will adopt for packaging the PROMs data. This could be HL7 FHIR, Open Air, or something else, and that's still to be finalised. Our decision will in part depend on the PROM suppliers used by health boards, but I suspect we will take a hybrid approach in this regard. Lastly is governance. Clearly, if we have standards, then we need to ensure we have protocols in place to manage updates and changes to these standards. Next slide, please. So in the previous slide, I mentioned processes. In our context, processes refer to the pathway across which we collect PROMs, and ensure we have minimum collection points along the pathway for each of our nationally validated PROMs. We have about 38 nationally validated PROMs at the moment. This is important to ensure we compare and benchmark PROMs data across patients and across health boards on a like-for-like basis. The longitudinal collection points will depend on the patient care pathway and the specific PROMs related to that pathway. And those pathways could relate to planned care, chronic condition, cancer. PROMs pathways are typically a subset of the whole cycle of care clinical pathway. So this diagram illustrates or provides a very simple illustration of this. For example, PROMs will be collected at regular intervals during the referral stage, then at regular intervals at the pre-op stage until the intervention, for example, surgery, then at regular collection points post-surgery. Though during these interval collection points, there may be information exchanges taking place between the patient device and the health board systems. So what we are proposing are the minimum collection points. However, health boards can include additional collection points across the pathway if they wish. The patient pathway scenarios can be complex. For instance, a patient may be on multiple care pathways, and therefore we could be collecting multiple sets of PROM questionnaires across each of these pathways. Patients may go to different health boards and trusts for intervention, and therefore a patient could be completing PROMs at each of these health boards and trusts as part of the touch point. So what is important here is that all that data needs to come together to build a true picture for the patient, and that data made available in the National Welsh Clinical Portal. These complex scenarios are another reason for taking forward the PROM approach. So hopefully this brief illustration has been helpful. Next slide, please. Earlier, I mentioned data standards. The work we are doing is to take each of the nationally validated PROM questionnaires and map these into an information specification. We take each PROM question and assign a unique question reference ID. We identify the type of data and format of the data for each of the questions. We also capture the value sets for each question. All of this information then forms part of the rules we build when validating the data provided by the patient and when storing the data. So the National Information Specification in NHS Wales is referred to as DSCNs, or Data Standard Change Notices. So these specifications are important because they ensure we encode the questions consistently across health boards and PROM providers to then ensure we can consistently, to then ensure we are consistent in our collection to deliver like-for-like data comparisons later on. In addition, we also have defined what we call LPDS, or local PROMs data specifications. So these are PROM questionnaires that health board may wish to collect that is local to their organisation. So, for example, a consultant may wish to ask questions, ask their patient specific questions, which are not necessarily national questions. And therefore, distinguishing between national PROMs, i.e. DSCNs, and local PROMs is important. This is to ensure that local PROM stays within the health board only, and national PROMs can flow into the centre, which hopefully will become clearer later on. So we don't have time in this session to delve into this in more detail. However, I am happy to take further questions later on. Next slide, please. So one of the additional key DSCN documents is the metadata information specification. So the components of the metadata comprises key sets of data as shown on the right. So they're the document details, the patient details, the PROM details, and the event details. There's a whole range of different key elements here. Now, this information is important to ensure we can build the correct data linkages between the patient, the pathway, the questionnaires being completed, etc. The metadata is also to ensure we have consistent meaning of the data across the entire PROMs pathway, which is just as important. Next slide, please. So this slide provides an example of one PROMs pathway. In this case, it's the PROMs knee arthroplasty. This is a view from a health board perspective. So at the centre, you have the PROMs pathway, i.e. the schedule of when we collect PROMs, and the links showing the associated questionnaire types linked to that pathway. So in this example, we've got the 3 generic PROM questionnaires: About You, WAPI, and EQ5D. The OKS condition-specific questionnaire, and the additional pre and post questions that may be asked. When we collect the PROMs, we also tag the metadata as part of the data flow for reasons previously stated. Again, we don't have the opportunity to go into this in more detail in this presentation. Next slide, please. So this slide provides a high-level overview of how we will bring each of the touch points to life, illustrating end-to-end interoperability. So from the patient, the device the patient uses, the health board, and then into the National Collection Service. And I'll talk about each of these strands in a moment. So working from the left of the diagram, we have the device app the patient uses to complete their PROMs. And referring back to Stephen's presentation on the work the DSPP programme are delivering, it is in this area that our work in the Welsh Varian Health Centre will align with the DSPP programme. So we take a common approach to authentication management. We have a consistent set of rules to support secure data flows in and out from these patient platforms and the health board. Ensure we take a cohesive approach from a patient experience perspective as well. From the patient device, there could be two-way communication between the patient and the health board trust clinician. This is to support timely shared decision making. The patient may also be able to see their own completed questionnaires, PROM questionnaires, in the app device to support self-management of care. So there's a whole range of different opportunities here going forward. So once a patient completes their questionnaire, the data then flows into the health board, shown by the blue cloud. The vision is to support near real-time data flows to ensure we have timely data from patients as well. The health board then consumes and uses that PROMs data as collected to meet their own needs, including feeding local clinical portals and data repositories. On the data repository, we are working with Cardiff and Vale as an exemplar organisation to build PROMs data structure for local consumption. And the aim is then to share that knowledge experience as a template with all the remaining health boards and trusts. So we take a corporate approach to this for the benefit of all health boards and trusts. Where the data aligns to the DSCNs, as I've talked about earlier, i.e. the nationally validated PROMs, then we expect the health board to ensure that data flows into our central data collection repository shown by the green cloud. Maybe this takes a systems of systems approach, something we still need to confirm and define through the NDR programme. Anyway, the vision is for the data to flow from health boards to that central repository in real time. In the central collection repository, we then consume that data for our dashboards to support aggregation, comparison and benchmarking across health boards, trusts and other data sets. In addition, to ensure we can visualise the longitudinal PROMs data in the Welsh Clinical Portal. In other words, we bring the data to life as covered in the session yesterday, chaired by Alan Wardell and colleagues. To deliver what is presented in this diagram requires collaboration between health boards, NDR, DSPP, Digital Healthcare Wales and the Welsh Fire Health Centre. But hopefully you can see the ambition and what we're trying to achieve here. And we are on this journey to sort of plug each of these gaps as we move along. Next slide, please. So this diagram illustrates what the flow could look like when we scale up the proposed PROMs ecosystem across multiple health boards, trusts, and even multiple PROMs providers. So in this illustration, we've got multiple the same PROMs provider delivering services to two health boards here, and on the right hand side, irrespective of who the PROM provider is, if they're delivering this to our PSOM standards, then we've got the consistent collection to support our data flows to build the dashboards and visualizations. By having the data processes and interoperability standards in place aligned to the PSOM, we then have the agility and scalability to extend the PROM service to meet health boards' future needs and the future needs of the Welsh Fire Health Centre. Next slide, please. I think this is my final slide. So it is exciting times at the moment. There's a lot of work that has taken place and we are still on this journey. Hopefully this brief overview has provided useful insights into the amazing work we are progressing on data, processes and interoperability. I'll now hand over to Angela.
Sorry, Angela, you're just on mute.
Well, there you are. The Director of Digital Transformation doesn't know how to use her own mute button. Apologies to everybody. So I'm Angela Parrott. Syed and Stephen are always a really difficult act to follow, so I'm not going to try. I'm here to give a local perspective, I suppose, on those national programmes that, if you like, we are receiving, but we're actually also part of informing. And Syed, Stephen and I work very closely together. I hope what you're going to see is that we are working closely together and that what you've seen thematically throughout all of these presentations is that at the heart of what we're trying to achieve are patients and patient care. Next slide, please. So this is an extract of our Cardiff and Vale digital strategy, where our aim is to become a learning health and care system. And the key word there, I think, is learning. If you can click, please. So in order to learn, you need data. You have to collect it, analyse it. What's it telling you? Does it make sense? And then you have to understand what that story is. Once you have this, you can acknowledge, you can use the knowledge, which is the knowledge into practice piece, to make improvements in care for patients. And it's not just about making improvements to care for patients. What we want are informed and empowered patients who can really, really be involved in their own care. So if you could click again, please. What we want to get to is a place where what works and what doesn't work for our patients is understood. And so you can see on this slide, which is a direct extract from our strategy, that patient-reported outcomes are really key for us and are one of the basic tenets upon which our learning health and care system is built. Next slide, please. So you've heard a lot about architectures. Well, this again is straight out of our local Cardiff and Vale strategy. We're trying to build an architecture to deliver our ability to learn from data. So at the bottom in the sort of browny orange ellipse, you can see this is where the shared data lives. So this is healthcare data, it could be social care data, it can be other data. And the point is, this data pool or store traverses organisational boundaries. Now, above that ellipse, you can see 3 arrows and something that says open APIs, which I'll talk about a little bit more in a moment. But the purpose of those APIs is to serve up content. And content, data, information is consumed differently. So consuming the same data, but with different views, we have patients, we have clinicians, we have analysts. And our governance structure to deliver our digital strategy does have boards aligned around patients, clinicians and analysts. We also have another board which is about capabilities, which is putting digital proficiency and capability into the hands of our clinicians. Each of those boards is full of clinicians and informaticians driving delivery of our strategy, and in delivering our strategy, what we're actually going to do. I said I'd talk about APIs. So it's not about the thing, it's about open standards. So application program interfaces mean the data that you receive as a patient, a clinician or an analyst is relevant and it's meaningful to you. So this architecture, which is our aim, helps to get the whole picture of the person, the patient, the care. Rather than, which you heard Stephen talk about earlier, data that sits in lots of perhaps unconnected boxes, which means you only ever get part of the story. And we need the whole story to help us to improve patient care. If you can click, please. I quite like this slide, which I stole from the Cybersecurity Hub as an explanation for what APIs do. So the back end, if you like, that's the national data resource, the local data resource, which is that pool of data I referred to a moment ago. The front end, well, those are the interfaces for patients, clinicians and analysts. That's where you consume the data that you want. The APIs serve up your content. And in this slide, what this means in the restaurant analogy is that you will get served the meal that you want in a way that you want to consume it. And that's really critical for us when we are looking at digital solutions that we're going to put into the hands of our patients, clinicians and channels, that it's going to deliver them what they need. Next slide, please. Thank you. So happily, the local architecture design that we have at Cardiff and Vale is very nicely aligned with the national architecture as part of the Value in Health programme. So if we can click, please. Once here you can see in this ellipse the shared data. So the national data, sorry, beg your pardon, one sec. Yeah, so here you can see the data being pooled, the national data resource. You can click again. Here's the patient informing that data pool by providing information, but also receiving content. Click and click. So there you are. You've got clinicians and analysts also part of this picture, which is exactly what we have in our local architecture plans. We've worked really closely with both Saeed and Stephen to make sure that we can effectively deliver on our ambitions in our digital strategy, and we talk and co-produce regularly so that whatever we're doing locally and whatever is happening nationally is aligned, because as I said earlier on, we've all got the patient at the heart of what we do. If we can click again, please. So this is an extract of our patient channel roadmap, if you like. It's relevant to patients. So you can see in those bubbles, these are things that patients might want to do. So they might want to exchange messages with their clinical team. They might want to review some resources that may help them manage their condition. They may want to send or receive letters, interact with us because we've got to arrange an appointment for care or a diagnostic. And PROMs are there as well, which is about how they can communicate with their clinical teams about how they're feeling. The risk is that we're asking patients to interact with lots of different solutions, and as a patient, that's not a great experience. We also know that we have to be proportionate. So, you know, this is feedback directly from patients. They may only want to interact once or twice, infrequently, with one or two of those bubbles, or they may have lots of requirements because they are receiving lots of care and services from us. So one size doesn't fit all, but that doesn't get us over this hurdle called the patient experience isn't great when they're trying to interact with us. So if you could click, please. We have an opportunity coming through Stephen's programme with the NHS Wales app, and if you can click again, please, which we hope is going to provide a single front door for the patient into all of the different things that the patient may need to interact with as part of receiving and informing their care. So it'll be a much better experience, but you can for the patient. But the API piece is really important because you'll still only be served up with the content that you want as a patient. If you can go to the next slide, please. So summing up really, and I've just realised I've rattled through that, so apologies. But Cardiff and Vale is a clinically led organisation. Our strategy was clinically led and still is. Delivery of our strategy is clinically led. And our hopes and aspirations for PROMs have been co-produced with our clinicians. They've also been co-produced in very close partnership with the National Value in Health team. And what that looks like is clinicians and Value in Health team have worked with us to develop a specification for what Cardiff and Vale needs from a PROM solution that will work for patients, that will work for clinicians, and will work for analysts. And that's throughout the whole of the process, from designing what our requirements are through to how the solution will work, how people will contribute and receive data and content, all the way through to the conclusion of the evaluation process, and that's kind of where we are now. And that actually concludes my piece. Thank you.
Thank you, Angela. And thank you again, Stephen, for your presentations. So hopefully the insight from the three presentations covering the journey from delivering the patient-facing app to the standard approach being taken around based on the PSOM and the health board perspective had been useful insight. So moving on to questions. So there's a couple of technical questions, but I'll hang fire and answer those towards the end. A couple of questions for Stephen to start with. What are the timescales for delivering the shared environment to support the core services or does this already exist for NHS Wales?
So it doesn't exist, apologies. Yeah, I am peddling jam tomorrow to a certain extent, although I have been known to point out that I can almost smell the toast in the toaster. So it's just around the corner. We've actually signed the contract with our development partners, Kainos, and Kainos have proposed an approach in Wales where they take the code base for the NHS app in England, and NHS Digital have agreed to allow them to do that and allow us to use that as our starting point. So we get a huge leg up with something that actually works on a scale with about 16 million users. And we're starting our discovery within the programme on Monday, so 4 weeks of discovery to really baseline the vision and the plans and the technical detail, and then we move into proof of concept, which was an 8-week piece of work which concludes towards the end of January 2022, and by the end of proof of concept we should have set up the components of the technology so that we can have an end-to-end demonstration of it working, but not yet capable of deployment on a grand scale. And then the third work package, which takes us to the end of March and possibly into April 2022, we scale up for deployment on a scale of the size of Wales. So in terms of having the thing up and running, it is going to be in about the next 6 months, maybe slightly quicker if things go well. But then we start ramping up what we call in the kind of the resource centre and the documentation and the sandbox environment that developers can access and download technical documentation and start really aligning with what we're doing. So that's our current plan, although we're under some pressure to run in parallel with we're doing some Pathfinder projects to demonstrate the kind of the future vision and the plug and play aspect of it. But also to an extent we are also working in step with the NDR programme, because in many ways that data interoperability service, which is a key component of all of this, is really a part of the vision for the National Data Resource Centre. And DSPP, like any other digital service, is really a consumer of that service. So the actual management of the API environment for Wales is an NDR type service, and they've just recently let a contract for someone to come in and set that up and operate it. And we're working with the NDR team to set that up and get it established. And we are a customer of that service. So in parallel, we're working with the NDR to get that service set up, and the timescales for that are yet to be published. But as I say, the timescales for DSPP are to have something up and running as a set of core services on a scale of the size of Wales by spring 2022.
That's great. Thanks to you, Stephen. I think the second question you partly answered in your session. Is it intended that a PROMs platform would be one of the core app services, or would that depend on health boards or PROM suppliers?
So this is the useful distinction between setting up the core and running a number of projects to set up those core services, and what we call in kind of Pathfinder projects, and we haven't actually yet got a better term for the future of these kind of projects around the edges or on the kind of the service delivery interface. But we're calling them Pathfinder at this stage because they are kind of proving how those projects might work, and the balance between support from a central core team and facilitating a project around the periphery and bringing the expertise from the health boards and service delivery into those projects. And the 4 Pathfinder projects we're running are quite diverse. So one of them is in primary care, and that's large and complex and steering a fine line between lifting and shifting the functionality of the NHS app in England, which will be there very rapidly. The need for a future for My Health Online, which is a web-based primary care tool primarily, and the support and the vision of DSPP, which is far more than just supporting services in primary care. So that Pathfinder project is addressing quite a lot of complex questions in that space. We've got a Pathfinder project that we're talking about today in PROMs, working with Saeed and Value and Health Wales and with Angela and Cardiff and Bale to see how DSPP can support those activities. And to answer the question, that Pathfinder project will develop a model for PROMs that may be multi-provider. For me, it really demonstrates the kind of the organisational architecture, if you like, of DSPP core services supporting a kind of plug and play of proven solutions around the edges. And those proven solutions really need to be, they're coming together of a service transformation desire in the health board, a team of people that are working in a particular area that want to change and deploy PROMs, a technical third-party provider that can actually surface that PROM and help the user complete it, which is not part of DSPP but is part of the kind of PROMs delivery, and feed that through the national PROMs model that Saeed has talked about into the kind of the bigger picture in Wales. And really the Pathfinder project is demonstrating how that works and to what extent that is multiple different solutions and different technical providers for different organisations in Wales versus a more kind of standardised approach. I have no view as to how that will land. But that's the nature of the learning that we expect from that Pathfinder project. And then the other two Pathfinder projects are in, as I say, PSA testing within our Bevan Health Board to demonstrate the concept of plug and play and DSPP supporting a project in that area. And then a project to look at improving the data interoperability to large scale deployments of third-party solutions like Doctor and Patients Know Best, etc. And to move the interfaces that support those into the more into a technology of interoperability that is aligned with the national architecture for Wales. So really we're at the stage of just learning through those Pathfinder projects what the best balance is between fewer solutions deployed across Wales or a complete free-for-all of market-led solutions. And I suspect we will have a bit of everything depending on the nature and complexity of the service that's being supported with digital services. So apologies, that was a slightly round the houses answer to the question, but basically we don't know. The Pathfinder project will decide to what extent it's appropriate to have multiple service offerings with multiple third-party technical partners in there versus consolidating on single approaches.
That's great. Thank you, Stephen. That's been useful information. I'll move on to Angela next. There's a couple of questions, if that's okay, Angela. The first one is, what would success for Cardiff and Vale look like with the implementation of the open architecture approach for PROMs?
So what it would look like is we're a learning health and care system, not to be trite about it. So what we want to achieve is that we have empowered and informed patients. We have clinicians with data that's provided by and informed by patients that enables them to really help, that enables them to improve and transform the clinical services and solutions and care that are delivered to patients. We want patients fully involved in their care. And the digital component of that really is that what we use and what we make available to our patients and to our clinicians and to our analysts, because that's all part of the same thing, is frictionless digital solutions. And that's why having things as part of our design considerations, like, so what does it feel like for you as a person having to interact with digital things, that has to be frictionless, so lowest barrier to entry. And so in that, to coin a phrase that's been much used by many national and other bodies over the years, if we can provide you with a capability that works for you, then you'll use it. So that, I think, probably summarises what we're hoping for. And of course, let's not forget about the interoperability of data.
That's great. That's useful insight again for our colleagues and delegates. Just last question for yourself, Angela, at the moment. So what are the timescales for implementing the PROMs using the open architecture approach?
So we wanted to have done it by now. we live in the real world, so we've just gone through a process, as you know, Saeed, because the Value in Health team have supported us as well with our clinicians. So we hope that we will be in a position to start mobilising a solution the end of this month, first week of December, if not before. And what that will look like is we've got a small project team. We already have huge interest from our clinical community in Cardiff and Vale. So we're starting to have targeted conversations with clinical areas about who wants to, who can go first, so that we get this thing out into the hands of our patients as quickly as possible.
Thank you, Angela. There's a whole range of technical questions and other bits and pieces which I'll take. So, and also some related to the work we're doing on the PROM. So the first question, well, not the first question, but the next question which I'll take is: have all the health boards bought into the PROM approach, and what challenges do you envisage will exist with implementing this? Yes, we did a roadshow back early in the year with all the health boards, with the chief information officers, clinical leads, promoting the work, and everybody could see the benefits of what we're trying to achieve. Clearly, from the PROM work around the principles and approach, we've also defined a specification document that forms part of a tender process for health boards to use, and that's the process Cardiff and Vale have initially gone through, gone up to procurement for a PROMs provider and solution that aligns to everything we've set out in the PROM. And hopefully, as part of that learning curve and experience, we can then share a whole range of information to the remaining health boards and trust to roll this out. I know there's other health boards keen to use that tender specification for their own implementation of PROMs going forward. So yes, absolutely. Challenges. There's always challenges with these things. In terms of the DSCNs, I mean, those that are not familiar with DSCNs, they are effectively mandated documents once approved by the Welsh Information Standards Board, so health boards have to implement them. So in some ways that drives some of the approach. Clearly the other challenge there is around the local PROMs data specification, because that's obviously questionnaires that the health board want to collect at a local level. So it's really trying to build the data model that can try and cater for both needs. Absolutely achievable. I think the biggest challenge linked to that is being clear in terms of what is that payload structure going to look like. So there's been a lot of discussions and debate around that over the last year. And that links nicely to another question associated with that, which is there's a lot of links. A lot of this links nicely to the work done on orthopedics PROMs. Archetypes and templates have been created in open air. Would be wonderful to collaborate if you go with the open air. Go with open air in Wales. And again, we haven't ruled anything out. Clearly, what we want to try and do, especially through the Cardiff tender to start with, is see what works as part of what we need to build for Cardiff, and lots of lessons learned there, and then we can use that to help inform our decision. So there's another question, again linked to that very point: are the electronic PROMs collection system used in Wales fire compliant? I'm not sure I fully understand the question. So there's obviously, when we talk about fire or HL7 fire, there's two parts to this. There's the information exchange, as I've mentioned. So that's really about how you flow the data between two touch points, and then the data interoperability side of it, which is your resources and profiles. So there is some work taking place by some health boards to look at the data side of it. Clearly, there's some constraints around, not within fire, but within some of the assumptions we made when we built the DSCN metadata around what value sets we need to capture. Clearly that will need to be reviewed as we learn from fire or HL7 fire. But for the information exchange, that is what the NDR program are taking forward. So it will be compliant from that perspective, because that is going to be a national approach anyway. Take a few more questions. There's a question here around, you mentioned the use of 38 validated PROMs. Looking at the examples, these seem to be constructed for randomized clinical trials. Is NHS Wales also using ISHOM standard sets that are designed for use in clinical practice and international benchmarking? So the 38 PROMs were created because the clinical network in Wales have agreed the validated PROMs to use. We are also using ISHOM sets where the clinical network have agreed to this. Yes, some of the national validated PROMs are aligned to ISHOM, as I've just mentioned. So yeah, we do have a combination of both. So hopefully that answered that particular question. So there's some general questions. Oh, here's one around, are we developing similar data flow standards, etc. for PROMs? So the focus initially has been on PROMs, but the principles of PSOM, in fact, PSOM could stand for PROMs and PROMs standard operating model. So the principles kind of work for both, recognizing that PROMs is different in terms of the questions we're asking. It's just not something we've actively looked at this point in time, but it is something we will look at as we develop and mature what we're trying to deliver through the PSOM approach. Conscious we've got a couple of minutes, so I'll just try and go through a couple of more questions. There's international interest in what you're doing in this program, e.g. US Health Department. How do you think we can generate the increased interest in NHS Wales in adopting PROMs? I suppose there is, how do you think we can generate the increase? I think this is back to down to individual health boards and trusts really, and I think linked to that is getting the right technologies, infrastructure and services in place. As we've talked about through the PSOM, really what we want to try and do, and in fact it's also linked to a lot of the other sessions we've had all week, because some of the challenges from a patient point of view is having that dialogue with their clinician, the two-way interaction, self-management of care, and having that shared decision making. So if we can get these technologies in place, then we can promote the use of PROMs much wider, and having the standards to then analyse the data will also support some of that activity as well. So yeah, so we're on a journey, and I think as we develop what we're trying to deliver, this will just hopefully increase. The last question I can see we've got is, how confident are you suppliers will align their platform, to support the DSCN and LPDS coding structures presented? So when we went on this journey around the DSCNs and the local PROM data specifications, we did test that with a number of suppliers. There's nothing coming back from the process, and this has been evident through the Cardiff and Vale tender exercise, that there's any sort of major showstoppers in terms of the approach. There are suppliers out there that more than comfortably align to what we're trying to deliver, and they can actually see the benefits of what we're trying to do and are keen to work with us. So this is where we're trying to route them through our innovation partnership teams to support that kind of engagement exercise. I'm just trying to see if there's any further questions. Hopefully that answered that question as well. I think that's it in terms of questions. So once again, can I just thank Stephen and Angela for your presentation and for answering questions. So unless there's anything else, this brings this session to a close. So thank you for listening and joining the session.
Thanks.